All right, for our last video, we're going to be discussing the neurocognitive disorders. So this section of the DSM really includes two major categories of mental disorders, delirium and then major and minor neurocognitive disorders. Delirium kind of involves shifting of one's attention and a kind of confusion that sets in for some people when they're experiencing delirium. And major and mild neurocognitive disorders involve cognitive decline from a prior level of functioning that impact a variety of different aspects of folks' cognitions. So important to this is really to look at the cognitive domains that are impacted by these disorders. The first domain would be complex attention. So this is people's ability to pay attention to what is going on, to remain oriented to people, to situations, and to conversations. So for folks who are experiencing either delirium or a neurocognitive disorder, they may have really divided or selective attention, that they're able to focus on some things but not on other things, and they may have a delay in their processing speeds. They may be taking longer to understand and comprehend what is going on around them. Next would be in executive functioning. There can be some impairments here. So in executive functioning just means people's ability to kind of plan for basic tasks and, well, maybe not necessarily basic, but basic and complex tasks that they have in their lives. And these require working memory and the ability to really override habits and have some kind of flexibility towards responding to situations that they're in. So an impairment in executive functioning might be forgetting how to brush one's teeth or how to prepare a meal. Learning and memory is another domain that's impacted by these disorders. So thinking about the impact on immediate long-term memory and implicit learning, the sort of things that we know how to do subtly because we've done them over the course of our lives. So people may forget things that they were just told. They may forget who they are. They may forget family members. They may forget what year it is. Next would be in language. So there may be some challenges with expressive language, people struggling to name things, remembering what the word is for such and such, challenges with grammar or with syntax, kind of putting words in unusual places that don't match up with whatever their native language is. And then receptive language, so really understanding what it is that people are saying, being able to kind of comprehend and make sense of normal conversations. And then the last domain would be perceptual and motor, so would be perceptual and motor, so having some challenges related to sight, to sound, to smell, to taste, or to some of their motor capacities. So that kind of sense of being able to do hand-eye coordination could be impacted. So, perhaps people were kneaders or into cross-stitch or something like that when they were earlier in their lives. They might struggle with something like that in the presence of a neurocognitive disorder. And lastly, sort of social cognition, so being able to make sense of the emotions and the social situations in which they find themselves in. And also kind of being able to recognize what it is that people are feeling or thinking. So we're going to start first with the major and mild neurocognitive disorders. So in previous versions of the DSM, these were called dementia. And really the key symptom of these disorders are some cognitive decline from people's previous baselines. And they often include symptoms such as memory loss, loss of judgment, coordination, recognizing folks, difficulties with speech, or even language. The mild and major neurocognitive disorders are diagnosed separately, and they differ mainly in terms of their severity. The major classification requires evidence of cognitive decline, and requires evidence of significant cognitive decline, whereas mild requires only a modest decline. Additionally to this, to classify for major neurocognitive disorder, there need to be substantial impairments and a person's ability to independently complete their activities of daily living. With a mild classification, on the other hand, these cognitive deficits not necessarily interfere with the person's ability to do what they need to do in the world to take care of themselves. So for some of these disorders, there are lots of different specifiers, for subtypes, for medical subtypes, which we'll talk a little bit about briefly. And there's also a specifier for with or without behavior disturbance. For many people with neurocognitive disorders, there may be changes in personality, unusual behavior, things like aggression, in people who prior to the onset of this disorder had no such history. So let's see here. These are often illnesses of age, so the rates of major neurocognitive disorder dramatically increase after the age of 65, and really at age 85, the rate is about 30%. Of course, the prognosis is poor. Overall, neurocognitive disorders like neurodevelopmental and delirium tend to be progressive diseases. Scratch that. Delirium is not necessarily progressive disease, but neurocognitive disorders are progressive diseases and are marked by degeneration over time. So it's pretty rare that people are ever able to really recover functionally. I think the best we can do is hold things steady. So here are some of the coding areas. When you're assessing people for these two disorders, it's going to be really important to do what we call a mini mental status exam. So the mini mental status exam is really a screening tool that can assess for both delirium and major and minor neurocognitive disorders. And it consists of 11 weighted questions, which really assess 5 distinct areas: language, recall, attention, and calculation, orientation, and registration. It tends to ask questions that include things like what year is it, asking clients to spell a 5-letter word backwards, asking the client to recall 3 objects after you say them and then recall them later, and then having clients copy a figure that is placed in front of them. And really any difficulty correctly completing these items would suggest that there's perhaps delirium or a neurocognitive disorder. And so when you are actually coding for these things, you would want to use the MMSE to do this, and then here's what you would want to kind of mark down in your assessment of someone. Again, these are the aspects of the mini mental status exam, plus the interpersonal, intrapersonal, and any psychotic features, which are not included in the MMSE. Here are the codes for some of the major and minor neurocognitive disorders. As you can see, this is where you would want to be really specific about which one it is. Obviously, major neurocognitive disorder due to Alzheimer's is different than minor neurocognitive disorders that's due to HIV. So there are lots of different forms of this disorder, and lots of them have various physiological root causes. So be specific here and make sure that you're getting some medical confirmation or diagnosis to go along with your supporting diagnosis. So in terms of treatment planning for mild and moderate neurocognitive disorder, obviously these have physiological reasons. These are disorders that really relate to something that's going on in the brain. So it's going to be important to have a medical professional involved in your treatment plan. In terms of thinking about prevention, anything you can do to kind of help people stay engaged and keep their brain healthy will be a good thing to do. Drawing from some of the things we've learned from neuroscience, encouraging people to do some adult learning courses, maybe play games on the internet, practicing an instrument, playing bridge. All of these things are great ways to have people continue to keep their mind sharp and to practice their memory. Another prevention strategy is really behavior activation, really trying to kind of help clients get connected to things out in the community so they're not sort of staying at home and being isolated. Exercise is another great thing to do, really supports growth and brain health overall, in addition to keeping your body healthy. So these are some great preventative ways of stopping perhaps the progression of this disorder. And then in terms of intervention and treatment, you'll always want to make sure that you're referring to a psychiatrist. These are conditions that are largely, well, I shouldn't say largely, but to some extent outside the scope of our practice. But good intervention options would be something like family systems, trying to get family members to be involved in your client's care, helping them to figure out how they can adapt and adjust to the new roles that they've found themselves in, and also making sure that the people in the family are connected with support on their own. Caring for a loved one with a cognitive disorder is taxing and stressful and difficult, and so that can be a part of the work that you're doing too. And also really being realistic about the fact that these tend to be progressive illnesses, and so helping families, helping clients continue to plan for their decline would be a good strategy. So our next disorder is delirium. So delirium is really kind of a sudden disturbance in attention or awareness. Often it arises when people are in the hospital or they're struggling with a medical condition, and you'll notice that they suddenly have no awareness of who they are, who you are, why they're there, what's been going on, and they may perhaps be easily distractible or unable to kind of sustain a conversation with you if you were in the hospital room, perhaps assessing them. There are often additional disturbances in cognition, so people may have difficulty with their working memory, with language, with communication. Ultimately, like I said, this comes on quickly, and it fluctuates during the day. So some parts of the day people will be sharp, some other parts of the day people will be a little bit more confused and disoriented. Often delirium is somehow related to either a medical condition someone's having or perhaps to substance use. The common one that we think about is substance withdrawal, particularly alcohol. In the case of alcohol, there's even a name for it. It's called delirium tremens, or the DTs, and this disorder happens when people have been drinking heavily and suddenly they stop drinking, and they start to get very confused, they get agitated, and often can be a precursor to death. So always want to make sure that when you're assessing someone with a drinking issue to ask about any family history of delirium tremens or any personal history, because this is one way in which withdrawal from substances can be life-threatening. And again, this has a specifier of acute or persistent, so it lasts for hours or days, or persistent weeks or months. And then there's two specifiers of hyperactive, hypoactive, or mixed. So are they moving around a lot more? Are they less active than usual? Or are they a little bit of both, depending on the time of the day? And here is the coding. So like I said, this is often related to medical conditions or to a substance use disorder. And so when you're coding delirium, you'll really want to specify what medical condition's going on or what substance use disorder it is, and whether it is induced by use or if it's induced by withdrawal. So I'm just going to quickly show a little section of this video just to see what delirium can look like.
What is this thing? Get me out of here. Mr. Williams. Mr. Williams. Yeah, what? Mr. Williams, what's going on? I want to get out of here. Mr. Williams. You're keeping me. I don't want to stay here. Mr. Williams, I'm the nurse practitioner. Barb, remember me from yesterday? No, I don't. You're in the hospital. Get me out of here. Let me get your glasses for you.
Delirium is a sudden onset of confusion that can happen when someone becomes ill. It can happen at any age, but those most at risk are the very young, the very old, and the very sick.
Delirium.
So as you can see from that, this gentleman is in the hospital, obviously for medical treatment, and he sort of wakes up and he's very confused and he's agitated and he's not sure what's going on. So that's what delirium looks like. Obviously, this is something that requires some medical intervention and potentially could be dangerous. So that's all we have for neurocognitive disorders.